We're ready to reconvene. We're at item 4, which is ACA implementation. Thank you.
Thank you. As part of the implementation of the Affordable Care Act, the legislature took many different actions, and one area was expansion of the eligibility provisions that are allowing for a streamlined enrollment process, and it means for the department providing additional guidance to our counties, to stakeholders, as well as IT system changes. And we've begun those efforts, and we're requesting 8 limited-term positions to continue that work. There's a question from the committee about the LAO's analysis looking at the ongoing need, especially for the 4 positions within our eligibility division. And the reason why we see this long-term is this isn't just about providing guidance one time, through which we're doing in many cases through information notices as well as all-county letter, but then looking at our regulations and changing our regulations. And then we also have to, this is fundamentally changing the whole eligibility rules and going back and changing existing rules and regulations that are out there. It's important to make sure that there's clear guidance, and that's going to take several years.
Okay. Any comments from Finance, LAO?
Thank you, Madam Chair. Just based on the implementation timelines provided in the request, it appears that the activities performed by the 4 positions in the eligibility division would be completed by June 2015. Now, the department has indicated that the activities of these positions will continue beyond 2015. So we're just seeking more clarity on exactly what those positions will be doing and what the workload associated with those positions will be prior to recommending approval of this proposal.
Good. Sounds great. Okay. And those were the questions we had, too, in terms of hopefully getting that information before we have to make the decision as to what role they'll be playing when it doesn't appear in the proposal. Okay. Any public comments?
Beth Capel for Health Access California here in support of the administration's proposal. At the rate they're going in the Medi-Cal transition, this may be their proposal may be the optimistic version.
Vanessa Kahina with the Western Center on Law and Poverty, certainly in support of positions to assist DHCS in determining eligibility. It takes people to enroll people, and appreciate the work that the department has done on this to date. Thank you.
Thank you. Okay. We will once again hold this over, waiting for additional clarification and information. Okay? That then moves us to item number 5. Okay?
Hi, Mary Cantwell again. This is a BCP related to our hospital presumptive eligibility program. Did want to just give a brief update on the program. Under this program, we were able to provide up to 60 days of full scope coverage for individuals who come into the hospital and complete a very brief application and look that they are likely eligible for Medi-Cal while they complete a full application. The good news is that through the end of March, we've had nearly 28,000 people get enrolled through the hospital presumptive eligibility program, and we have 163 approved hospital presumptive eligibility providers. So in terms of the BCP itself, this is a request just for funding, not for positions, and this funding is going to be used to hire IT consultants to assist us in enhancing the business functionalities and reporting capabilities of the med system required for the hospital PE program. Since we did need to get it up and running January 1st, 2014, we relied on existing infrastructure, but that infrastructure doesn't have everything we need in order to meet the requirements from CMS on program oversight, monitoring, having performance standards measurement, and ensuring integrity and compliance. So this funding would help to make sure that the IT systems are brought up to where they need to be to keep this program running.
Good. Any comments from Finance? LAO? Sounds good. Any public comments?
Beth Capel for Health Access California. We supported hospital presumptive eligibility. We support the staff recommendation.
Great. Okay. I think that probably I don't think there's any other questions, any comments. Basically, I thought it was a good proposal, one very necessary, and glad to know that we have the ability to enroll them in the hospitals. That's great. Let's try issue number 6, which is the ACA Managed Care Bridge Plans.
Sure. So we had submitted this BCP, but given the lack of federal approval so far and the unknown time frame for which federal approval will be obtained, we don't believe resources are needed right now, and we'll revisit the need for resources at a later time. So we're withdrawing this BCP.
Withdrawing proposal. Okay. Sounds good. Issue number 7. Item number 6 is being withdrawn at this time. Issue number 7.
All right. So another important component of the state's implementation of the Affordable Care Act was the expansion of, or is the expansion of, our substance use disorder treatment benefits as well as mental health benefits. The legislature and the administration expanded these benefits, our mental health benefits through our managed care plans, as well as substance use benefits that we're working with our counties to implement, and this includes intensive outpatient treatment, residential, as well as inpatient detox. We are working to implement those benefits. We recently received state plan approval for several of the benefits. We're still working on the residential treatment benefit to get federal approval. And as part of the implementation of these additional benefits, we're requesting additional positions to be able to implement this, 22 positions throughout the department, given the enormity of the work, both working with our counties as well as guidance, IT work, and it will take several years to implement all these changes that really are going to improve overall health and integration of the health, as well as substance use benefits. So, any questions? Okay.
Any comments from Finance? LAO? No comments? Any public comments? Okay. Thank you very much. This item will be held over for voting. It, too, is an item as a result of what was passed by the legislature with ACA. That takes us to item number 8, which is ACA Medi-Cal eligibility integration with CAHERS. Okay.
The California Health Eligibility and Enrollment and Retention System we call CalHERS, which publicly facing to the public is referred to as our covered cal.com website, is a joint system that between the Department of Healthcare Services and Covered California that serves as both the website for enrollment into affordable health coverage, whether Medi-Cal or Covered Cal plans, as well as the rules engine for modified adjusted gross income. It interfaces with our 3 statewide automated welfare systems, our SAS systems, as well as our MED system, which is our client index, and also interfaces with what's called the federal hub, including all different identity management and determining income, as well as immigration status and citizenship. This was a complicated IT project. Most IT projects like this would take 3-4 years that we implemented in less than 18 months. That being said, while we had it up and running by October and have continued to implement it, it has not been without its challenges. An enormity, that successfully have been able to implement, but there have been challenges both in terms of the interfaces, getting the interfaces with our county SAS systems, as well as the performance of the system. At times, the response has been more than anyone ever projected, which has been a good thing, and the system just has not had the capacity to deal with it, which is really no fault of the system, but just the tremendous response. Other areas is because of the fact that the system hasn't been able to make all the changes in a timely manner that we all need. So this BCP, we are requesting resources within our department for working on CalHERS of 12 positions. But I'll also answer, you have several questions in addition about, first is around the delays and challenges that we've experienced. And as I said, it mainly due both in terms of the timeline, the enormity of the challenge, both in terms of getting this up and running for open enrollment in October, as well as the need to interface with the multiple systems. And so we had to put certain scope off, and it's taken some of the scope that we still have not been able to get to that we thought we would be able to implement. These have had big challenges on the most important component of the system, the people who need to get coverage and need to get onto coverage as soon as possible. And individuals have been experiencing delays in getting coverage, getting their benefits, as well as the response time when they're on the system. And this then impacts our county workforce and our county workers in terms of their ability to do their work and be able to do, as they've transitioned to a whole new culture of providing an eligibility enrollment in a one-and-done environment. It slowed them down. So there have been implications and challenges that we are working through. In terms of addressing it, we're focusing as much as possible on the critical nature. I'd say now that ever since the open enrollment began, we've been focusing on bringing up the interface between the SAW systems and then working through the performance of that interface and figuring out ways to improve the response time, as well as there are many different subpopulations in terms of certain rules that we need to change, and we're putting those into priority order to change those so that we can make sure that if there's certain populations not getting on, we fix the system. In the meantime, we're providing guidance to our counties on workarounds, but prioritizing all the system changes so that we can not focus on workarounds that are more labor intensive and get the system to where we want it to be. As I said, in terms of capacity of the system, there was so much tremendous response for coverage on the final days at the end of March that not everyone was able to get on the system, and Covered California made a decision to allow anyone who tried to get onto the system or anyone who started the application to be able to have until the 15th of this month to continue, so they're continuing. That also means the intersection with Medi-Cal to the extent that anyone applied and was potentially eligible for Medi-Cal, and it turns out later that they're eligible for Covered California. That will be an exception to the open enrollment, and they'll be allowed to get on to Covered California at that time. And another piece, just one, is that we're continuing to work on the messaging now that open enrollment is over. We're working with our partners at Covered California. Medi-Cal enrollment is year-round. People don't know that they're necessarily eligible for Medi-Cal, so we need to work on how do we publicly message continuing to enroll, with at the same time letting them know that they're not necessarily eligible for Covered California if they don't meet one of the exceptions. So we'll be working on with stakeholders and Covered California on focus group testing the best way to message that. But in the meantime, we're working on the website messaging until that's done. So I'll leave it at that.
Okay.
Thank you.
Thank you. Any comments from Finance? LAO? Okay. Mr. Dickinson? No questions. Any comments from the public? 1 minute each.
Vanessa Kahina with the Western Center on Law and Poverty. We are, I think, top line is thrilled that millions of people are in the process of getting into health coverage right now, whether that be through Medi-Cal or through Covered California, and that on January 1, the effect of health reform bringing eligible people into coverage through the low-income health program transition, the CalFresh system, and all of the express lane enrollment options that DHCS took up. However, there are extremely serious concerns that Director Douglas has alluded to, and problems getting in the way of Californians getting the needed medical coverage and services because of these eligibility delays. Today, there are about 800,000 pending Medi-Cal cases because of a system problem or more information needed from the beneficiaries. We applaud the administration's decision some weeks back, which we pushed for, to allow for self-attestation of residency for these pending cases, as well as new applicants in March and April. There's really no incentives for someone living in another state to try and get a Medi-Cal card, and the state has not made good on its promise yet of checking for state residency electronically. This change alone is estimated to clear half of the cases. That's huge progress, but it still leaves several 100,000 Medi-Cal coverage people in limbo for the time being. We urge that the suspension of residency verification be extended until all electronic data sources can verify residency and are available, rather than the current arbitrary cutoff date at the end of April. In the middle of hundreds of thousands of pending cases,
Could you sum up, please?
Yes, that we have expressed concerns also about the website right now. It seems to indicate that you can't still apply for coverage through Medi-Cal. There is no open enrollment date for Medi-Cal, and we'll continue to work the administration, but we appreciate your attention to these concerns.
Thank you.
Lucy Quatchinella on behalf of Maternal and Child Health Access. We're very appreciative of all that's been achieved. It's truly historic, and we acknowledge that up front. However, as the Los Angeles Times reported on April 4th, we have 800,000 pending applications. There are a number of policy decisions. The tech, the support, the additional staff, we strongly support that. That's needed. But the policy decisions that the department has within its jurisdiction to make would be a dramatic improvement to clearing that backlog. For example, the state of New York has decided not to make people submit paper proof of their income if they're on unemployment insurance, in acknowledgement of how often the federal e-verification hub is down, and an acknowledgement of the fact that those databases, even when they are available for query, are months out of date. Other states are taking similar measures so that they didn't build up this backlog. California could, at the very least, adopt self-attestation of income for people with unemployment insurance and similar types of situations so that we deal with this sooner rather than later. We're hearing from the field that in many of the counties, they don't think, even with the additional proposals of staff, that they'll be able to clear out these backlogs for up to 6 months or more. That's really not acceptable, and so we thank the department for all the great work to date, but we really need to take the policy decisions, not just the tech fixes, but the policy decisions to do more better. Thanks.
Thank you.
Hi, Beth Malinowski, California Primary Care Association. I want to second the comments made by the other consumer advocates. Just want to add to the conversation that in addition to the resources that are needed in the future, as others have highlighted, resources are needed today, both to make these important decisions and to help lead on thinking about our policy changes, but also on resources on the ground. Not only do we have to think about those that are still pending in our system today, as others have referenced, the 800,000 people, but additionally, we are about to embark on 2014 renewals for pre-ACA enrollees, and we want to make sure the same system that they are going to have to run through is up and running so that we don't create new problems, new challenges for folks that are already enrolled in programs of coverage. Thank you.
Beth Capel for Health Access California. We would join Western Center and others in urging a continued suspension of paper verification of residency. We think that the department made the right decision to do that, but there's no reason to end it on April 1st. We should do that until electronic verification is operational. And we would also encourage exploration of additional means of doing self-attestation or electronic verification. Thank you.
Thank you. Okay. Any other comments, questions? Okay, if not, then thank you very much. We'll move to item number 9, which is budgeting methodology for county administration.
As part of last year's budget, one of the important change was adding additional funding for our county workers to do the processing that you've heard about right now. That's even more than we ever expected. And we added additional funding into the budget both this year as well as in budget year. The other piece was looking at the overall methodology and knowing that given that the eligibility determination process is changing dramatically, to modified adjusted gross income. You heard about while we're not doing every type of streamlining, there's a lot of electronic verification of income, of all different types of documentation, and then the renewal process is changing dramatically. But at the same time, our caseload is growing significantly, so there's a lot of different moving pieces. So part of the budget last year was statute to look at redoing the methodology and determining the right amount of funding, whether it's higher or lower, that counties receive. And we have a budget proposal of both consultants as well as state staff to do this work to assess how much time it takes to do different types of activities and the cost of doing that so that we can pay our county workers to do this important work over the long haul. So that's what this proposal is about.
Okay. Any comments? Okay. LAO? No comments? Did you have any comments, Mr. Dickinson? Okay. Yes. You'll have a minute.
Thank you, Madam Chair. Frank Mecca with the County Welfare Directors Association. We take no issue with the department's need for resources for this important function, which we supported in statute. We had some concerns with the original draft of the BCP, and we've made good progress with the department working through some of those issues. We expect to work out some trailer bill language that we would ask the committee to consider when the issue is taken up again. The sort of last sticking point from our standpoint is the placement of auditors into the Audits and Investigation Unit as part of a process for developing a budgeting methodology. It seems odd to us and sort of inconsistent with the function at hand for staff developing a budgeting methodology to be reporting to an Audits and Investigations Unit, which culturally and by statute has a different mandate. We're still talking to the department about this issue, and we hope we can work something out on that regard, but that is our last and final thing that we think we have to sort of resolve with the department to be supportive of the BCP.
Okay. Mr. Dickinson.
I just want to share, I share the concern raised by CWDA about this given the objective. So I'll be interested to see how this is addressed when we come back around to this.
Yeah, my assumption is that you're working it out and figuring out why we're needing auditors versus someone else. Okay? All right. Sounds good. Thank you very much. That takes us to item, that item will be held over also. That takes us now to item number 10, which is Medi-Cal County Cost of Living Adjustment.
The next item that's it relates to annually as part of the way we do our county administration budget for our county eligibility determination process is a cost of living adjustment. But given the last year that we increased the funding by roughly $120 million that was associated with the additional workload, the administration determined that there was to do the cost of living adjustment in addition was not needed, that the $120 million covered that, and so we're proposing to spend for this period of time and no longer do the COLA while we have the $120 million, and then we're moving to the new methodology after that point.
Okay. Any comments from Finance?
Madam Chair, Yang Legal Department of Finance. I just wanted to point out that this language that we have, that we're proposing, is consistent with existing statute, which has eliminated annual COLAs for all state programs.
Okay. Any comments from LAO?
We recommend the legislature reject this proposed trailer bill language. In our view, the proposed language is premature. As you just heard, statutory language passed last year requires DHCS to work with counties to develop a new budgeting methodology. And in our view, any discussion of the ongoing nature of COLAs should be part of this broader discussion of the new budget methodology that's being developed. Until the new budget methodology is developed and adopted, to the extent the legislature chooses to suspend COLAs for county administration, it can do so through the annual budget process, consistent with what has been done in recent years.
Thank you. Comments?
Frank Mecca with CWDA, and we agree completely with the Legislative Analyst's Office.
Thank you.
Kelly Brooks Lindsay on behalf of the California State Association of Counties. We're also opposed to the elimination of the administration's proposed trailer bill. Thank you.
Thank you.
Beth Capel on behalf of Health Access California. We concur with the LAO. We further note that the unsung stars of the rollout of the Affordable Care Act in California are our county Medi-Cal eligibility offices, which have answered the phone on time, unlike Calvert, California, and unlike the many health insurers who are also unable to deal with the workload. It is, and it was in part because this legislature adequately funded their work. Thank you.
Thank you.
Vanessa Hina with the Western Center on Law and Poverty, in concurrence with our partners at CWDA and the LAO in this analysis, and we urge you to reject the administration's proposal. Thank you.
Thank you. Mr. Dickinson?
Thank you, Madam Chair. I just want to say I also agree with LAO on this one, and I have to say that I have very painful memories during the time I was a county supervisor of COLAs for more than 10 years. Not being added for the purpose of the cost of doing business, and so an automatic suspension does not make sense to me. It seems to me it ought to be something that is looked at on an annual basis, and if it is addressed to the satisfaction of all the parties and whatever the new budgetary methodology is going to be, fine. We'll look at it then, but. Between now and then, we ought to consider this on a year-by-year basis, so we don't have a repeat of what happened for more than a decade to counties.
Okay, thank you very much. Our staff recommendation is that we would reject this proposal, so we'll be looking forward to hearing from the staff with regards to why we should not, obviously. But I think most of us agree that it's somewhat premature, agree with LAO. So at that point, we will hold that item over and move on to item number 11. Community Health, Mental Health Services Overview.
Good afternoon. Karen Baylor, Deputy Director of Mental Health, Substance Use Disorders, Department of Healthcare Services. This is just a quick overview of the community mental health services. DHCS administers and oversees the 1915B specialty mental health waiver for Medi-Cal beneficiaries with a specific diagnosis. We provide outpatient services and a variety of services underneath that, and inpatient services. With the ACA, it has allowed the expansion for Medi-Cal program to include childless adults whose income is at or below 138% of the federal poverty level. Back in January 1st, 2014, the benefits were expanded over into the managed care plans, and they will provide services to the mild to moderate impairment, and those services include individual and group psychological testing, outpatient services for the purposes of monitoring medication therapy, psychiatric consultation, and outpatient lab drug supplies and supplements. Any questions?
You. Okay. Any comments from LAL? This is an informational item. Did you have any questions? Okay. Since it's only informational, we'll move on to item number 12, which talks about 2011 realignment.
Carla Castaneda, Department of Finance. As your agenda notes, there is currently $27.9 million available to allocate to counties. The state continues to be in discussions with counties on how best to allocate those dollars. The questions noted in your agenda are exactly the items we continue to discuss.
Okay. Any comments? Anyone else? Okay. Mr. Dickinson? Any public comments? Yes.
Good afternoon. Thank you, Madam Chair, members. Rusty Selix, California Council of Community Mental Health Agencies. We note that we're at the time of the year, the last 3 months of the fiscal year, which contract providers, which our agencies are, reach what are called contract caps. And in order to go beyond those caps, the counties have to identify that they will have additional money. What we've been waiting for the state to identify is to clarify the policy that if a county has services, particularly for children under the EPSDT program, which is operated as an entitlement, where counties were, until realignment, only responsible for 5% of the cost, that would come off the top out of growth. The state has said that to us privately 3 times. We note that Finance mentioned the state is talking to the counties. The state is also talking to the stakeholders, but separately, not together. So we don't know what they're telling the counties. But what they've told us privately 3 times is that, yes, EPSDT is an entitlement, as is alcohol and drug, and that must come off the top out of growth if counties spend more. We would like to see the state say that publicly and quickly, because each week that goes by without the state confirming that that is what the policy is going to be based on means there is an increasingly greater risk that providers are going to hit those caps, and many are being told that their counties believe that if they spend more, it comes at their expense, that there will be no additional state spending. As a result, they're telling providers they cannot provide additional services to these very seriously emotionally disturbed children. So what we're hoping is the state could provide that clarification, ideally today, if not, then very soon.
Thank you.
Good afternoon. Wesley Sheffield from Young Minds Advocacy Project. And I'm here to express concern that the current funding structure is creating impediments to access for children who are eligible for EPSDT services. We think that a big part of the problem is that it remains unclear what happens if the allocation is insufficient to meet the costs of actually delivering services to youth. And then with that policy being unclear, counties are understandably hesitant to expand the program. We've seen increasing evidence that counties are, in fact, treating the program as a cap program. We've heard numerous reports from providers saying that counties are telling them that they can't expand the program, citing allocations as a constraint for expanding the program, that they need to restrict services. And we're very concerned that that this is restricting access for youth. We think that the growth allocation formula presents an opportunity to overcome the disinvestment and ensure compliance with the EPSDT program. We urge the state to adopt a guarantee for counties that they will be reimbursed for all EPSDT expenditures, and that allocations moving forward will be based on actual expenditures rather than historic formula. We think these two components will encourage investment into the program and ensure compliance with the EPSDT entitlement. Thank you.
Thank you.
Good afternoon, Kirsten Barlow on behalf of the California Mental Health Directors Association, and specifically in terms of the growth allocation formula not having been developed yet. As far as we understand, the behavioral health program area that was realigned in 2011 is the only one where the base and growth numbers have still yet to been firmly established, which is really creating a lot of uncertainty at the local level, not only for the current budget, but also for next year's budget, as counties build their next year budget on the current one, which has already had to be produced for the Board of Supervisors without this critical piece of information about what kind of growth revenues and what their baseline will really look like in the future. Wanted to just mention, because it's being raised by many of the provider organizations in terms of this perception that the program may be treated as a capped program. County mental health departments truly do understand the fact that this is and has been always an entitlement program, the EPSDT piece, as well as the Medi-Cal specialty mental health services that adults receive. We also understand, as part of the structure of realignment, that the statute says that counties must not only use their 2011 realignment to pay for EPSDT mental health, but also our 91 realignment and Prop 63. So we have to take all of those revenue sources into account locally to provide revenues to support the services we provide to children and adults. But also, in terms of the reports,
sum up?
Yes, in terms of the reports about the capped program, there could be cases in which a county is saying to a local provider that the contract they have is capped, that they're providing specific resources to them, but that doesn't mean the program as a whole is capped.
Thank you.